This may be the, I'm presenting now maybe the bad aspect of spinal surgery, or even maybe the bad aspect of medicine in general. Patient with spinal metastasis. This is just an overview. Spinal metastasis, the increase in number of spinal increase of number of primary disease or primary malignant disease increase as the number of patients getting older and older. These patients or this group of patients are the source of considerable morbidity in cancer patients. And spinal metastasis would be either extradural or intradural, and the majority are extradural. Early diagnosis of these patients results in a reduction of pain, improved or preserve the quality of life and neurological functions, and maximize also the quality of life. And understanding the epidemiology and presentation of the disease is essential to develop a strategy of management or diagnostic strategy as well. The rational treatment may involve chemotherapy, steroid therapy, radiotherapy, surgery, and/or percutaneous procedures. The epidemiology of the spinal metastasis has been reported that over 20,000 patients with metastatic spinal cord compression are reported annually. And 70% of cancer this patient has metastasis on the source, and 14% of these are symptomatic. In order of frequency, the skeletal system comes third after the lung and liver as a host of metastasis. And also the lumbar metastasis come after the thoracic metastasis as a host of metastasis. The source of primary source of metastasis can be the breast, prostate, lung, renal, and the blood in this order of frequency. How they present? Pain is the most common presentation in spinal metastasis. It is up to 90% of patients, and it is poorly characterized, progressive, and relevant, and non-mechanical unless this severe destruction or instability. And presentation at night is indicative of malignancy. Neurologically, these are frequently come after pain. Usually they come after pain. Patients start usually with active pain followed by neurology or neurological manifestation. If the tumor is eccentric, involving one of the appendages of the vertebral body, there is a rapid onset of root or cord compression. Sometimes the neurological manifestations are subtle that they may needed to be qualified or quantified using one of the major scales like the Asian scales or the French scales. And very rarely you might have a patient with complete quadriplegia or paraplegia. And also a presentation of compression fractures are common in these patients. Now, how to diagnose these patients or how to manage these patients? We have two groups of patients. Group one, where there is established metastatic disease with typical imaging. And this group of patients, you don't have a biopsy, you go and proceed and manage your patients directly, and you might need to repeat the oncological staging of these patients. And the other group is the group of patients with no prior diagnosis. And we have to know that spinal metastases are initial manifestation in 20% of cancer patients, and mostly they arise from the unknown origin carcinoma, lung carcinoma, multiple myeloma, and lymphoma. For these patients with unknown or with no prior diagnosis before, we have to have a protocol of diagnostic for these patients. This protocol involves the history, physical examination, routine lab work, and whole body scanning, and then radiography, CT, chest, abdomen, and pelvis. And with this collective protocol, you might identify primary in 85% of patients. And if you add biopsy, you might add another 8% for diagnosis, and you are up to 93% accuracy diagnosis with this protocol. CT guided biopsy is also very important, and its accuracy is about 90%, and it gives better results in lighting tumors or lighting metastases rather than solid metastases. Physical examination also is a very important tool to evaluate the patient with lumbar or spinal metastasis, and we have to look after the spine examination, the neurological examination, and health status of the patient as well. Deformity is one of the important points. You have to look for spinal metastasis, spinal deformity by naked eye with the back of the patient, also the point of tenderness, and we have also to know that 15% of patients with spinal metastasis has another metastasis elsewhere in the spine. Clinical instability and principality is one of the important points to mandate how we manage our patient, and also we have to consider the health status, the disease burden, because this determines the modality of treatment. And also we have to use standardized evaluation in order to evaluate the crack, pain, the neurological impairment, and also the performance status, because these are important points how to manage these patients later. This is two of the commonly used neurological scales, the Asian and the Spinal scale. We commonly use these to standardize or to quantify the neurological status of the patient. And also the performance status. This is the Karnofsky score and the Eastern Operative Oncology Group score. This score is important to quantify the function and the activity of the patient, and also it's important to determine how we are going to manage our patient. The prognosis of this group of patients is very important, and these are the factors that influence the prognosis. The primary tumor histology, the overall burden of the disease, and neurological status, as well as the performance status. And this is the impact of the primary on the longevity of the patient. We can see here that the longevity of the patient or the expected lifespan is more better in thyroid, breast, and is more bad in the patient with lung, renal, or unknown cancer. Also, the scoring system for prognosis. This is a scoring system for the prognosis and the criteria of predictive the prognosis. In this score, we use the condition, the general condition for the performance status, the number of extraspinal bony metastasis, number of metastasis in the vertebral body, and metastasis to major internal organ, and the primary site of cancer, and thirdly the neurology or the neurology of the patient or the neurological disease. And we calculate the score, and if we have the score from 0 to 8, now the longevity is less than 6 months. Between 9 and 11, the longevity is between 6 and 12 months. And if we have the score 12 to 15, now the longevity is more than 1 year. And this slide correlates between the total score and the longevity and the management. Because if you have a score between 0 and 8, now the longevity is less than 6 months. Now the treatment is non-surgical for palliative treatment. However, if you have a longevity of more than 12 months, now you go for excisional surgery or you give your patient a best shot. Also, for the evaluation of the patient, the imaging is very important, and we have to know that the plain X-ray is not sensitive, and we have to have 30 to 50% of trabecular bone destruction in order to have a positive X-ray. And also the blinking of signs or the reticular destruction is one of the important signs on the claim accuracy. Again, scan lack sensitivity about 50% or 90% accuracy, and provide greater anatomy details of the bone. The MRI is the best modality of treatment, the choice modality. It is very sensitive, 99%, very specific, and also accuracy is about 99%. It gives excellent details of extraspinal distance, neural compression, leptomeningeal disease, and adjacent level involvement. Whole spine is very important because we have to know that about 15% have more than one spinal metastasis. Another very important point is the risk of impending collapse, because if we have vertebral body involvement more than 30 to 40%, now this vertebra are going to collapse. And if we have 20 to 25% of vertebral involvement, plus posterior elements and or medical involvement, also this vertebra are going to collapse later. And because this is very important determinant of surgery, how we're going to treat this patient later. Management generally is must be individualized to each patient. This is based on the histology, the performance, burden of the disease, and the neurology itself. However, the treatment can be medical, radiotherapy, or surgery. Medical treatment is, we have to know that the chemotherapy is the mainstay. Steroid also has a very important role and commonly used. especially for radiosensitive tumor like lymphoma, myeloma, myeloma, but also intermediate sensitivity tumors, and have radiosensitive tumors like all other solid tumors. Surgery has a very important role, and the indication for surgery is the neurological compression, instability of pathological fractures, severe pain or uncontrolled pain also, and sometimes to define the pathology. And we have to know that the surgery should be circumferential. And surgery could be either anterior, posterior, or a combination of these. It can be en bloc resection of the tumors, or even vertebroplasty or kyphoplasty. This is an example of en bloc vertebrectomy done through posterior phase, where we remove the posterior port, and then anterior phase, and do just corpectomy stage. This is an algorithm. This algorithm showed us how to manage these patients, and it depends mainly on the neurological deficit, followed by spinal instability, and then by the severity of the pain. These are the three determinants of how we manage these patients. And finally, we have the response of each of these steps. Now, the take-home message from this overview is that improved cancer and cardiovascular therapy increase the incidence of spinal metastasis. Surgical treatment, medical treatment, and radiation treatment also improve life and prolong the survival of patients with spinal metastasis. And many studies across the literature have highlighted the role of carefully considered surgical therapy for such patients. And treatment strategy for spinal metastasis must be individualized patient by patient. And also the candidates for local control of the disease are the candidates who are asymptomatic and with pain without extra osseous risk of appendix fractures are the candidates for local control like vertebroplasty, kyphoplasty, or even local irradiations. And also steroids and radiotherapy yield an excellent result for tumors that are radiosensitive like lymphoma, myeloma. And finally, surgery for patients who survive more than 3 or 6 months and are able to tolerate general major surgery, who have neurological deficit, who have neural compression, instability, progressive symptoms, and dependent fractures, and finally inadequate pain relief. Thank you very much.